Testing, testing, 1, 2, 3. This is showtime. Testing, testing. Well, we're here again. Welcome. This is Dr. Minarcik preaching in a hollow auditorium right now. Today is Tuesday. It's December 4th. It is 8 a.m. here in Caguas, Puerto Rico at beautiful San Juan Bautista Medical School. Of course, it's 6 a.m. in Chicago, which is where I would normally be broadcasting from. This is our 25th session of Global Online Medical School Pathology, and it's also our 6th session in which we have been able to synchronize the online people, who I have always called the buzzards, with the Puerto Rican medical students, who I call the iguanas, because there's so many iguanas here. So welcome buzzards, welcome iguanas, and you might want to know that today all of the music was picked by me. I have so many people giving me requests, and eventually I'll get to them, but today I thought I would pick all the music myself. Well, we finally have the trickling in of the iguanas, so that's very, very nice to know. I guess we can do our audio-visual test. I know the people in the room can hear me. Maybe they would prefer not to hear me, but let's see if the people online can hear me too. I'm going to ask you two questions as our pathology exam. Number one is, can you hear me? Okay, can you hear me well, or can you hear me as well as yesterday? Good, that's very, very nice to know. Another question that I want to ask you is, how was the music? I know we have a way to fix the music and make it better, but we weren't able to do it today. But from here on in, I promise we are going to have perfectly crystal clear music, even better than Chicago. I just couldn't do it today. So the question is, what do you see on your screen right now? And if the buzzards get the right answer, the iguanas are going to smile over here. So the answer, what do you see on your screen? Colored pencils. Okay, you know, did you ever remember the smell of a colored pencil, how nice it smelled? When I took a look at that picture, especially when I maximized it, I could almost smell the freshly cut wood. Oh, I really, really like pictures like that. Okay, so here's what we're going to do now. We've officially opened, we've officially done all of our audio-visual tests. And I have always written a few things down on a piece of paper, because when I go to sleep at night, I say, you know, don't forget to tell them tomorrow this and this and this. So I got a couple things I just want to say, and none of them will be long ranting and ravings. I guess what we could call our session today, Female 3. Now, you know, we've had two hardcore long sessions so far, each a couple of hours at least, on the female reproductive system. The first session was basically a discussion of the diseases of all of the Mullerian structures. What we spent our time on yesterday were diseases of the non-Mullerian structures, like the ovary, diseases of pregnancy, and diseases of placenta. And today, I guess you could call it Female 3, because we're going to have a fun day today. I absolutely know it, even though I didn't get a hell of a lot of sleep last night, thanks to this guy that's sitting in front of me right now, who is going to be doing our PowerPoints, by the way. So I'm going to give him a couple of devices here. They work very well, just to make sure that you're awake this morning. And what we're going to do in the first hour, maybe a little bit longer, is run through the discussion of the diseases of the female breast. We may throw in one tiny bit at the end about the male breast as well. But as you know, in women, breast carcinoma is the #1 cancer in terms of incidence, and very, very high up there in terms of mortality as well. Not #1 anymore. Lung has taken that over, but at least #2. And probably we'll have a break then in the midpoint, and then in the second half of the session today, we're going to catch up on what I call histopathology lab. So I have chosen about 20 slides from the male reproductive system and the female reproductive system and the breast, which we're going to be looking at live under the microscope. And in that case, I'll take the mouse away from Mario, and I'll start having you sit with me around the microscope. Okay. The thing I wanted to remind everybody about, and I don't think I've said this before, is that I know, like, I don't feel bad when there's just a handful of people here. I really don't, because I got people up there, and I know that a lot of people have even watched me, attended our sessions online, even if they're students here, and that's good. So I wanted to just reassure you that as soon as we walk out of this classroom at approximately 10 o'clock, 11 o'clock at the very latest, but hopefully more reasonable today around 10 in 2 hours. Usually within 2 hours, that entire session, everything you see here, everything you hear here will be online, because the computers here are faster than what I've been used to in Chicago, and also the internet is a lot faster too for uploading. So when I leave this room, I run into my office and I start doing massive copying of movie files and then processing and then compressing them 2 different ways. And this is very, very time intensive for slower computers. But so far, unless there's some kind of major interruption, all of the things we do today, which will take 2 hours, will be up online within 2 hours. Okay, and now for the very last announcement, and this pertains to the people that are here, and not at all for the people that are online. The people online don't have to suffer the anxiety of a test from me or from your school. They probably have to suffer the anxiety of exams from their own school, you know, and I'm sorry for that, but I don't want to be accused of giving exams or giving grades or playing God. I just want to be accused of providing educational resources for anybody that wants to use it or doesn't want to use it. So here's the algorithm. By the end of today, which is Tuesday, we will have completely finished the entire discussion on female repro, okay, which is considerably bigger than male repro. Now, what we're going to do tomorrow, and we probably will not do this online. It'll probably be a non-online session tomorrow. What we're going to do tomorrow is a review for the exam. Now let me explain this, because I've been struggling with this for several weeks now. I am one of the privileged people who has access to the exam. I saw the exam. I wish I could have made the questions up myself, but you know that's not how it's done over here. These are board level questions, which we may have some role in selecting, but very often we don't have even a role in selecting, because the very last thing I ever want to do is teach a whole bunch of people for weeks and then find out that some idiot who sits on the board has asked a question who has no concept of the important pathology points I've been trying to stress. So what we're going to do tomorrow, and this is public knowledge, you could share this with everybody, I am going to go over all of the exam questions. I've looked at them briefly already with a fine-tooth comb, and I'm going to ask myself this after every question. I'm going to say, does this pertain in any way to pathology? You know, and as you know, a lot of them don't. They pertain more to microbiology or pharm or something like that. But if it pertains to pathology, I'm going to go back to all my PowerPoint slides I've been showing you for the last 2 weeks, and I'm going to put a little mark on that slide. I'm going to say, okay, well, if this is a question about Gardnerella, for example, I'm going to make sure that we review, vaginal infections. And I'm going to, I'm not going to at all let the cat out of the bag. I'm not going to tell you the answers, I don't need that kind of trouble. But I want to make sure that when you sit in front of that computer on Thursday, and I believe you were not able to get it delayed, correct? That you can feel that at least I've done my part. I think it's the moral duty to make sure that even though they don't make up the questions, to make sure that when you take those that are points that they covered, and as you know, often they're not. But I don't want to be accused of that. So that's what we're going to do. And I don't think we're going to be online tomorrow. I think we're going to do this privately, unless there's a massive response here from the buzzards that say, let's do this together. We'll do it online. So we could do a vote. I mean, remember, this is only a review for an exam that doesn't pertain to the pathology in general. So if I could see 5 or 6 people right now that are absolutely thrilled or with the possibility of doing the exam review, I'll put it online. Otherwise, I won't. What are they saying, Mario? They want it or they don't want it? Uh, Already, is anybody saying no? Okay, so then we'll put it online, okay? And it'll be online for also, remember, 2 hours after we get out of here, this is going to be on your computer. Another thing I want to tell you, and is that for the people that have sit in these chairs here, and they happen to be also online on the webinar, on the iPod, they can actually see some of the fine details in pathology, both gross and microscopic details that they can't even see by looking at that screen. So what does that tell you? What that tells you is that I should have one of those big sledgehammers in my hand right now, knocking down the walls of every medical school auditorium in the United States, because the students shouldn't be online just for convenience. They could see better and they can hear better. So anyway, I've made all the announcements. I guess it's about time we get into the actual topics here today. We're going to start out with diseases of the breast. It's a relatively short chapter. I would like to say it's my favorite one, but if I did say it was my favorite one, I would lose all credibility, because so far I told you every chapter is my favorite one. You know, but I really, really like breast a lot. And of course, you know, with all the things that pathologists examine every day, breast is probably one of the highest volume and one of the highest areas of liability. You know, when I started in pathology, nobody was ever sued for, having a disagreement with another pathologist about a breast biopsy. Now it happens routinely. It's so defensive. So let's start out with the breast. That's the best picture of the breast that I could Google. And I want you to remember from your gross anatomy, remember they told you that there was a certain amount of lactiferous ducts in the breast. You remember what that number was offhand? It was more than a handful. It was like 15, 12, 20, something around there. Well, every lactiferous duct, it doesn't necessarily lead separately to the nipple. It may join. You may have only 3 or 4 or 5 openings. But those lactiferous ducts determine the number of lobes in the breast. And the number of lobes, they're not really separated. You can't dissect out one lobe from a breast. It's impossible. So that's really a good picture showing at least 1 or 2 lobes. Point out the big single lobe on top if you can. There you go. Just draw a big circle around it. And technically, those, 15, 20 lobes will lead to their own lactiferous ducts. And you see how some of the lactiferous ducts join there at the nipple. So when you see these pictures of women that have prolactinomas or are lactating, you don't see 17 little pinpoint areas of milk on the nipple. You maybe see 3 or 4 or 5. So those ducts do confluence. Is that the right word? Okay, but let's get going. That's just the title page. Okay? There you go. Something you've seen a lot of, hopefully, in your anatomy lab. You saw that big breast plopped right on top of primarily the pectoralis major, maybe a little bit of overlap with the pectoralis minor. You know the breast is nothing but a modified apocrine sweat gland, right? So you know that the apocrine sweat glands are only in the axilla and the groin in the body and nowhere else. Well, a development of that, a differentiation of that is called the female breast. And if you remember, the lateral thoracic artery, which runs on the serratus anterior, sends major branches to the breast laterally. And the internal thoracic artery, you probably called it internal thoracic, but for generations I just called it internal mammary. All the older surgeons call it the internal mammary because it fed the breast from the medial aspect. And what more can we say? You've probably seen that before. Let's go on to the next one. When you are examining the breast lymph nodes, obviously the easiest ones to examine and the ones that drain probably the vast majority of the breast. I was going to say 90%, but it's probably like 75, are the axillary lymph nodes. But remember, you have that chain of lymph nodes along your internal thoracic artery, which can receive both inflammatory as well as neoplastic changes from the breast. And last but not least, do you remember those supraclavicular lymph nodes? Sometimes they pick up metastases from breast carcinoma as well. So a supraclavicular lymph node in a woman sometimes is a sign of a breast carcinoma, even if the axillary nodes are negative. And if you could guess, most of the tumors that originate in the upper and in the lateral portion first will go to the axillary. And just from your anatomic orientation, probably a tumor, for example, along the medial aspect of the breast might be more likely to go to the internal mammary. And then finally, something superiorly, if you look at the drainage here, might go to a supraclavicular node. So those are the lymphatic areas. So you think it's only axillary, you're going to be wrong. Next one. Okay, we talked about a lobe. I put there 10, but I was being a little bit stingy that day. I really looked it up again when I did my fact finding last night, because every year I update these and I want to make sure that I don't say something wrong or stupid. So it's really more like 15 on the average. That's what you call a lobe. Every lobe has its own lactiferous ducts. The lobes are not different from each other microscopically and grossly. They may just probably blend in to some areas of fat. Now, what is a lobule? A lobule is a portion of a lobe. And what is an acinus? Or an alveolus, if you will. An acinus or an alveolus is a portion of a lobule. So those are your three levels of differentiation. Lobe, lobule, acinus. Anything that leads in or out to these structures in any way for transportation of the fluid of the milk is called the duct. Okay? Most of the carcinomas of the breast are ductal carcinomas. Most of them are. You can have technically alveolar or lobular carcinomas as well, but they're not nearly as common. So what else do we want to say except to remember the general organization? Next one. Okay, there's your lobe. Next one. There's your lobule. Now, whereas you can see the lobules are generally organized into groups of acini. So there's what, maybe 20 or 30 acini within that lobule, but there might be 20, 30, 50, or 100 or more lobules within the lobe. So point out the lobe, if you can, the whole lobe. Okay, now point out the lobule. Now point out an acinus. Okay, what do you think the cells are called that make up the acinus? They're called acinar cells. And remember the cells that have kind of a contractile function that are peripheral to them? You know, those are called myoepithelial cells because they have a contractile function like muscle. Okay, and that's very, very important as well. Now, if you were to dissect this breast grossly, do you think you could dissect out that lobe? It's just not possible. I've never seen it done, even by master surgeons. There's no reason to do it. It's just a level of anatomic integrity that we're talking about here. Next one. Okay, now there's your acinus. Okay, and you have your very clear-cut acinar cells. And then you may or may not see, in fact, I'm going to tell you, Mario, to use your imagination, or actually you don't, because if you look at that acinus, do you see a little spindly cell towards the periphery of the acinus? It looks like it's superiorly located. That's probably a myoepithelial cell, okay? There's a lot more. Yeah, that's a blow-up of it over there, by the way. So, I don't know. It'd be hard to call. But I think if you see a smaller cell, I don't know. Let's just say that in all honesty, there's nothing I would see on there that I would say is absolutely an acinar cell. I mean, you could do stains for a myoepithelial cell. You could do stains for them and everything, but it doesn't matter. Next one. Okay, now on scanning electron microscopy, you could see that the acinus is surrounded by processes from these myoepithelial cells. Okay? So you have two kinds of cells in the acinus, epithelial and myoepithelial. Next one. And if you just want to call the epithelial cells acinar cells, you can. Next one. Okay. Now, I want you to go back 2 or 3 notches, and I want to show you something. I want you, this is, oh, maybe, okay, good, good, good. Okay, this is a really good question because it's a logical question, and all I got to do is have the mentality of a 3-year-old kid to answer it. If you were to make a computer matrix, you know, of that digital picture there, how many of the pixels would be blue and how many of the pixels would be pink? Give me the absolute most safest answer in the world. It'd probably be 50-50, right? Well, keep that in mind because when you're examining a breast, it's usually about, and she is a pre-menopausal female that's not lactating and not pregnant. It's about a 50-50 ratio. Now, what do you think happens to that ratio of epithelial to connective tissue or blue to pink after menopause? It goes down, doesn't it? Because remember, withdrawal of estrogens means withdrawal of development of the acini. What do you think happens to that ratio if she is pregnant or lactating? It goes up. Now, this is the most important thing. When I was in China last year, some of the students asked me about the way this is organized. And I wasn't normally going to say this. So I took them to the window, okay? And I could probably take you to this window as well. And I'll say, look at the trees down there. As every tree is completely different, right? But you can still recognize them as a tree, whether it's a tree in China, a tree in Puerto Rico, a tree in Lake Bluff. No trees are the same, but they generally are growing like trees. I says, well, what if all of a sudden you saw something like a tree, but rather than having, you know, a nice little stalk called a trunk and all this, it just kind of grew haphazardly in all directions, you know. The trunks were going that way and the leaves were going into the ground. I says, that's how you generally visualize the process of not only a breast infiltrating or malignant neoplasm, but it's the growth pattern. And I want you to remember something that is independent of the way that the cells or the nuclei look like. So any pathologist in the world will say that's a lobule. You know, even if they zoom into the cells of the acinus and they look as malignant as all hell, of course they won't. They'll say, why is it a lobule? Because it looks like a lobule. It's growing like a lobule. And there's no 2 lobules that look the same either. So when you examine a slide like this, you don't have to go to high power to tell the surgeon or tell the patient that it's benign. You say it's growing like a normal tree. I hope I made the point clear because that's really going to come up so often when we study the other parts of pathology, especially neoplasm as well. Okay, let's go to where we kind of left off before. Okay, so what we said, active, by active I mean a premenopausal woman that's non-pregnant, non-lactating. Those trees cover about as much surface area as the ground. It's about a 50-50 ratio. Now, most of the breast biopsies that we deal with are older women. They're postmenopausal, especially if there's suspicion for a mass or a lump or a cyst or a malignancy. So in most of the breast specimens that pathologists see, it's less than 50% because they're generally more atrophic, loss of estrogen. It's not likely we would see too many breast biopsies in a pregnant or lactating woman. But we'll show you a picture of that. If it's not here, then we'll show you in lab. Next one. Okay? Oh my God. You know, there's not a single word on that PowerPoint, okay? But I want you to memorize it anyway. I just want you to look at it and take a quick mental snapshot and say, look at, those are all trees, those are all lobules. We don't have to look closely to see that the nuclei are malignant. We know they're in the ratio between connective tissue overall and epithelium is about 50-50. If I had to, you know, show you the world's most perfectly normal and high quality microscopic normal premenopausal breast, that would be it. As a matter of fact, I didn't Google that image. I actually got it from our virtual microscope. Next one. Okay, now you're worried. You're looking at this. But let me ask you a question. Even though you know that ratio is really up now, can I please ask you, does it still look like a lobule? Yeah. So you have a lobule here in which not only do you have an increased number of epithelial cells, you probably wouldn't want to call that hyperplasia because what's inside the little acini? Milk. This is a lactating breast. What's the difference between a lactating breast and a pregnant breast? Sometimes you really can't tell, but if I was to give you I call that lactating, but it's probably pregnancy rather than lactating. You want to know why? Because if it was lactating, it would be so engorged with milk, not just those little pink droplets. Want to point some out, Mario? Yeah, those are the little milk, proteinaceous-like droplets inside of those acini. There's a real good one right underneath there. Yeah, there you go. If she was lactating or nursing rather than pregnant, that breast would look more like a thyroid than a breast. Okay, those acini would be really things. So there's not too many things in the body that look like thyroid other than thyroid, but a lactating breast is one of them. And the intermediate lobe of the pituitary is another one, if you kind of remember that. Next one. Okay, so here's the question. You got this on the exam now. And of course, I think the wise people there out in cyberspace, who I call the buzzards, they're probably going to get this right away. Here's your question. Is this a premenopausal normal breast, a postmenopausal normal breast, or a breast cancer, or a lactating breast, or a pregnant breast? And they're all saying normal postmenopausal. See, they still look like lobules, don't they? But they're less. Okay, you see that little kind of whitish area surrounding the acini? Those little whitish halos, sort of? No, not. Those are the blood vessels. Take a look at the acin itself. You see how you have the acini, and then you have looser connective tissue? Well, that's strictly an estrogen effect, and it would probably be a lot more noticeable if she was not postmenopausal. Yeah, well, that whole thing is a lobule, right? Yeah. And look, would you want to call that thing up in Montana up there? No, the little group down there, you want to call that a little lobule too? Or maybe it was part of a bigger lobule where you just cut through? Yeah, these are just something you get used to. Next one. Okay, quiz time again. I'll give you the same question. Is this breast cancer? Is this pregnancy or lactation? Is this a normal premenopausal, normal postmenopausal? I'll tell you, those things are awfully distended. Almost looks like thyroid. So either this is a lactating breast or somebody that's very, very pregnant. Okay? Next one. Oh, go back, please. Now, normally, if I was to show you this, you would say, oh my God, this got to be some kind of adenocarcinoma of some organ. But please, just remember one thing. You could still see the lobules, can't you? Oh, that's the most important concept. Next one. Not that I'm, training you to be little pathology residents here. Okay. Okay, the most important thing to understand in breast pathology is to get a solid image of the normal breast. And you've already took that picture, remember, in your mind. So that's the only thing you have to remember for my exam today. Next one. Okay. Now, there are developmental problems, congenital. We always start out with those. We talk about systems. There are probably degenerative changes of the breast, but probably, like with the ovary, it's hard to talk about degenerative changes of the breast when you realize that every breast sort of degenerates, after menopause, like ovaries do, like endometrium does. So if you were to ask the world's most famous breast pathologist, what are some of the degenerative changes of the breast other than normal postmenopausal changes, he would probably go, duh, and then think about it for a couple of minutes and then try to, give you some profound answer. Inflammatory changes? Well, it's a modified skin apocrine sweat gland, isn't it? So can skin become inflamed? Can sweat glands become inflamed? Sure, the same type of change. What type of organisms normally would inflame skin? Staph and strap. That's always like at the top of the list. Same thing with the breast for a mastitis. But remember also, you have a very, very, very intricate duct system in there as well. So technically, something that might obstruct a duct, whether it's fibrosis, whether it's inspissated milk, would not only be a factor for inflammation, but it would also be a factor for what would happen to the epithelium proximal to an obstruction in any part of a breast lobule. It'd tend to expand, right? So cystic changes. Next one. So let's talk about some of the classical developmental breast things. We talk about milk line remnants, accessory breast, nipple inversion, macromastia, every guy's favorite topic. Let's do the milk line remnants first. I bet you that if you go home tonight, and I'm talking to the girls here, and you ask your boyfriend, to draw a line between your axilla and your inguinal area. And of course, you have to put the nipple in the middle of that line too. And very often you just might see like, oh, I've had this little mole here my whole life, Very likely it's a small accessory nipple. It's very, very common. And sometimes they could be more than just nipples. You could have even a little bit of accessory breast tissue there as well, along the breast line or the milk line. But without a doubt, where is the most likely place to get accessory breast tissue? Towards the inferior portions of that line or in the axilla. So most accessory breast tissue is axillary. And you'll see a woman that looks like she has like a little extra fat there, which, everybody's entitled to have. But maybe it's more on one side. Very likely you biopsy that. That's going to have like breast tissue. Next one. You see that tiny little mole that this person, I don't know, it could be a guy too. Guys can have milk line remnants too. I've examined myself. I don't have any little moles along this area here, but if you do, they're a lot more common than you think. It may not just be a regular nevus. It might be a little bit of a accessory nipple remnant. Next one, developmental. Well, there's a woman with, pretty good-sized breasts, but there's also an extra little lump there in the axilla. Could that be fat? I would believe it if it was exactly the same way on the other side. But that's accessory breast tissue because that's normally where the tail of the breast is, isn't it? Next one. Oh, okay. No, we'll save that little comment for later. Let's look at the next one. Okay, here you have a little nipple inversion, okay? Now, if it's somebody that had a nipple inversion their whole life, she shouldn't go run into the doctor when she's 50 and saying, oh, do I have some cancer there, causing a scar and inverting that subareolar tissue. Most likely, most of these are congenital. However, things change. There's an awful lot of women getting their nipples pierced and all kinds of crazy things, their tongues, not just their earlobes anymore. So if it's an acquired person who's had a history of nipple earrings, okay, then then almost certainly, if it's acquired, it's going to be secondary to that because what follows an inflammatory reaction of putting something foreign in there would be fibrosis. Next one. Now also remember though, in a woman that has a nipple inversion and she has no history of piercing and it has not been there her whole life, what's the one thing that you're obliged to rule out? Even if there's nothing palpable, you have to make sure that get a mammogram to make sure that there's not something there that's causing scarring. Because remember, most of the carcinomas of the breast are called scarous. They evoke a lot of scar tissue, and if it's in the subareolar area, even if it's not palpable, for example, that may cause a nipple inversion. Okay, macromastia. Let me ask you this. It's a logical question. It's not a medical question. I think you'll get the right answer. So you have one woman that has small breasts, and you have one woman that has large breasts. This woman has 10 times the weight of a breast to this one, okay? Now, everything else being equal, genetics, age, blah, 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 risk factors, blah, blah, blah. Who do you think has a massively higher chance of getting breast cancer? the person, with a 5-pound breast or the person with a 5-ounce breast. Okay? The more breast tissue you have, whatever the factors are, whatever the carcinogens are, whatever the dietary and genetic factors are, the more breast tissue you have, the more likely you are to have a carcinoma. Everything else, but doesn't that make sense? Okay, good. I'm glad I see some nodding heads. Next one. Okay, atrophy. Why is that blank? Because I really can't think of any atrophic conditions of the breast other than the normal withdrawal of estrogens, which is not really an atrophic process. It's a normal process. Next one. But we showed you that before, and there you go. The ratio overall between the blue and the pink, between the epithelial and the stromal, is less than 50%. Yeah?
Would a total hysterectomy be a pathologic situation where you have atrophic breasts?
Hysterectomy?
Yeah, or like a total hysterectomy where you take the uterus and the ovaries, because then you have estrogen.
Oh, you mean in a premenopausal woman? Yeah. Next one. Inflammation. Well, whatever the bugs are from micro that generally cause, skin infections, cellulitis, abscesses, whatever, are probably the same bugs that are the highest on the list for the breast, because the breast is a modified skin gland. A lot of times the presence of the inflammation is described as, periductal or intraductal. If it's intraductal and it's acute, and it's a large duct, that might even result in a nipple discharge, wouldn't it? Okay, doesn't necessarily mean cancer. Another concept to remember of the breast, even though this is true with fat anywhere, and this is almost always caused by surgery, is if you take fat and you traumatize it by surgery, that fat's going to not look quite soft and yellow anymore. It's going to be a little bit harder. Sometimes it might even feel a little bit lumpy as well. That's called fat necrosis, almost always secondary to trauma. And in the breast, if a woman has had extensive surgery, most likely when you examine this, we're going to show you a picture, that's fat necrosis. Now, for some reason, I'm going to mention this. I don't think you'll ever see it. I can't remember the last time I saw one. If your primary infiltrate of inflammation around the lobules are pure old lymphocytes, you could probably call that chronic mastitis, right? Because it's lymphocytes. But if you'd rather call it a lymphocytic mastitis, it has a very high correlation of being in diabetic patients. Now, what about if you see granulomatous inflammation in the breast? Could it be sarcoid? Absolutely. Could it be TB? Of course. But most of the granulomatous mastitis is not culturing anything, okay? What is probably, okay, I just got this idea now. What do you think would be the most likely cause for granulomas in the breast? How about foreign bodies? Do you think that when women get implants and you examine the little fibrous membranes around those implants, you're going to see a foreign body giant cell reaction? Absolutely. In fact, we have a case. We'll be showing that, probably not showing it in lab, but these are just all considerations. Next one. Okay, so there's an acute mastitis. What does acute mean? Red, swollen, tender, painful, all the classical signs of acute inflammation. Most likely, if you biopsy that breast, you're probably going to see a lot of neutrophils as well, because it's acute. But here's the thing. Could it be only inflammation? Could it be acute inflammation secondary to a malignancy as well? Yeah, it could be. Okay, next one. What are almost 100% of the cells inside those ducts? 3 choices. I'll give you 5 choices. Eosinophils, neutrophils, lymphocytes, macrophages, or, sickle cells. I don't know. There's mostly neutrophils, aren't they? Acute mastitis, the simplest diagnosis in the world. If it was a large duct, could that be a discharge as well? Sure, if it was a larger ducts are closer to the surface. Next one. Okay, you do a cytology in your office on a woman that has a nipple discharge, and she has a big red, swollen, hot, tender breast. You see 100% neutrophils now, looking at it from a cytologic point of view. But don't forget, you may also see big, dark, malignant cells as well. Okay, so don't just look at that and say, oh yeah, a bunch of neutrophils. Generally, you would probably want to examine it more thoroughly, not you, but maybe the pathologist who does the cytology, to reassure the person that at least in this discharge, there are no malignant-looking epithelial cells. Does that rule out a cancer? Of course not. All it means is that there's no cells in that discharge. Next one. Okay, now I have to bring up another inflammatory concept just to be the devil's advocate here. Does that breast look inflamed? Is it red, swollen, blah, blah, blah? Okay, in addition, take a look at a close-up view of that now on the right. What is a common fruit that you might eat for breakfast in the morning, especially if it's squeezed, and it looks like that's the peel? That looks like an orange peel, right? So you have a big, swollen, generally diffuse breast. You have what they call, the French call, peau d'orange, or orange peel. Why does it look like that? Do you see? It looks like that because of the prominence of the ducts or the pores of the eccrine sweat glands. That's what you call an inflammatory carcinoma. Why is it edematous around all of those tiny little pores? Well, it's because the lymphatics are diffusely blocked by tumor cells. Now, let me ask you this. You know, every time a woman comes in for breast surgery, you know, they try to cure her, they try to get everything, of course. But let's say this woman comes in, she presents with a peau d'orange, and you even do one little skin biopsy. You don't have to be a surgeon. You can do a tiny skin biopsy. You see a few of those little cells in the lymphatics, tumor cells, and you go, this is an inflammatory carcinoma. Do you think the prognosis of an inflammatory carcinoma is horrendous? Do you think I've ever heard in my entire career of a woman surviving one? And not for very long, usually. Okay, so there's an orange peel, too. Take a good look at the orange peel on the right, and then take a good look at the real orange peel next, and that's why they call it peau d'orange. Yeah, there you go. You know what that is. Next one. Now, I know you're all getting really good at this. Now, Mario, don't get too quick on the trigger finger over there. But I want you to just look at that thing for a second first. And I want you to show me the lymphatic vessels in that skin that are loaded with epithelial cells. I can see 2 or 3 of them. You're absolutely right. That's one. No, right above it. There you go. What about on the other side? You see anything over there? Yeah. Those are obstructed lymphatics with dermal edema, making the pores or the eccrine sweat glands look prominent, and that's why it looks like an orange peel. Next one. Okay. That's breast. There's ducts of the breast. We don't even care right now whether, you know, it's benign, malignant, or anywhere in between. But what can you, in all honesty, say about those ducts? Is that they're inflamed. Now take a look at the one over there in Montana. I mean, that's a lot of periductal inflammation. Yeah, right there. Those are all lymphocytes surrounding that duct. So you call that periductal inflammation. There you go. Hey, there you go. We got both the laser pointer as well as the other one. If Mario screws up, whoever has the laser pointer, you know, oh, okay.
Do this one first and then the other one just.
Oh,
Yeah, I don't want to show the online people the wrong stuff.
okay. Now, we're not on high power here, though, either. But I want to ask you, what are 100% of those cells in that big periductal inflammation? Are they neutrophils or are they lymphocytes? Well, you know they're going to get the answer, right? What are they saying?
For some reason,
Are they hedging? Or do you have to slide it down to get it? Okay. Buzzards, what are those cells? Lymphocytes or neutrophils? I know they're going to get them, so you just have to find them. They're all saying lymphocytes? Okay. Why are they lymphocytes? Because there's hardly any cytoplasm. Remember in a lymphocyte? It's all round blue nucleus and very minimal cytoplasm. Whereas in a neutrophil, there's plenty of cytoplasm. Okay, was there a question? What's that?
the lymphocytes, right?
Yeah, those are all lymphs. In fact, Can I even make another suggestion? Not only are they all lymphs, but do you think that some of those lymphs are even differentiating into maybe a follicle? Remember the follicles, the secondary follicles, have a germinal center? Would somebody like to be brave enough to point out the germinal center in that big cluster of lymphs there? You see that little circular area of lighter lymphocytes? No, there you go. Go just a little bit west of that. There you go. That's a germinal center, isn't it? So you know those are lymphs. Next one. What do you call ductasia? You call ductasia dilatation of the ducts. Could it be secondary to inflammation? It usually is. Could it be secondary to obstruction? It usually is. But all they are dilated ducts. Now, what's another name for a dilated duct? Especially if it becomes really dilated, or you could see it on ultrasound, or you could pop it in the pathology lab. Cysts. So we want to call those small cysts or dilated ducts. It doesn't matter. And just offhand, I'm going to really put you on the spot again. Take a look at that little cluster there over in Oregon. That's still basically something that has a lobular configuration, doesn't it? Okay. Do you think that those cysts there are big enough to be picked up by ultrasound? That's debatable. They're hardly more than microscopic, but they could be. They look like they might be, 1 or 2 millimeters. Next one. Okay, now there's a big cyst. And there's a big cyst that's been cut down the middle. And you can see the upper part of it there and the bottom part, and it's filled gelatinous material. Could that be fibrocystic disease? Yeah. Could it also be a duct, for example, that's dilated because there are either malignant or pre-malignant changes going on inside of it? Yeah, but for the most part, when you look at a cyst and it's just filled with either fluid or gelatinous material and it shows up maybe on ultrasound as a nice little cyst, not much of a solid component. Most likely those are all benign. Next one. Okay. Now I have to introduce the concept of apocrine metaplasia. Do you remember we said that the entire breast is nothing but a modified apocrine sweat gland? Well, you have to remember that there are also certain types of cells that could line the ducts that are also called apocrine cells. And generally, apocrine cells are columnar cells, but they just happen to be redder than normal. And sometimes they have like a nice little bleb on their apical surface, which as well. So I want you to point out that cluster of apocrine cells there. Yeah, those are all apocrine cells. Now, they might even be lining some of those as well, but I don't really think so. Those would definitely be apocrine. And I'm just wondering if they look a lot better here on the monitor, because I don't think that the screen is really doing them justice. Oh yeah, those are as red as hell. So the people that are online are getting a better appreciation for the redness than the people that are here live. Next one. Fat necrosis. It's fat. It might look hemorrhagic. It's a little bit firmer than usual. It's not a distinct lobule, but it's probably almost all fat necrosis is secondary to some kind of trauma. Could it be somebody that's, fallen, or could it be fat necrosis from abdominal surgery? Yeah, it could be, but that's classically the gross appearance of fat necrosis, another common breast situation, especially in those who've had trauma or surgery. Next one. Okay. Now, do you see that there's still remnants of fat in there, but it's not quite as nice and loose as the normal fat that you see? So the thing to remember about fat necrosis is that if it's been traumatized, there's probably hemorrhage. So a lot of those little cells there that look granular, those are hemosiderin-laden macrophages. Do you want to point one out? Or if you can't see it well, I could point out some cells that, yeah, that's a good one. In fact, I think there's even a better one right above it. I would probably say you can see some blood pigment here. This is the best cluster here. There's a little bit over here. And it's a little bit more granular and golden. But what are all those other cells? Do they look like multinucleated macrophages or multinucleated histiocytes or giant cells? Is this ruptured fat and hemorrhage acting as a kind of a foreign body as well? Yeah, so a large portion of those cells that you see up there in the northeast that look like they have more than one nuclei. So what are the features of fat necrosis? Giant cells and chronic hemorrhage in macrophages too. Next one. Okay, I just throw this in the fat. I'm just throwing this as an extra. It's kind of a lobule, and most all of the cells that are infiltrating it are lymphocytes, and it could be really nonspecific chronic inflammation. But when the whole thing is like lymphocytic, you could call that lymphocytic mastitis, associated with, at the top of the list, diabetes. Next one, granulomatous mastitis. Could you point out a couple of multinucleated giant cells? Could you see how the whole general cluster centrally look like macrophages, histiocytes? And there's a cell right there in the middle. I think I could point it out too. I'm thinking I could probably see it a little bit better here. This is one of the world's best classical multinucleated giant cells. Oh, here's a great one over here. Oh, and here's a really good one over here. This is probably the best one right there. Can you see the multiple nuclei? Okay, next case. Granulomatous mastitis. You could culture it. You could look for TB. You could look for, well, you can't culture sarcoid, can you? But it could be sarcoid. But most likely in the breast, granulomatous inflammation is not secondary to a specific pathogen. Next one. Neoplasia. Well, that's the big discussion. We've been leading up to it. We're going to talk not about the main consideration in breast, and those are breast tumors. We're going to talk about factors. We're going to talk about patterns. And if you want to divide breast neoplasms into benign epithelial tumors, you can. If you want to talk about benign stroma or the connective tissue between the lobules, you could talk about that. If you want to talk about premalignant changes, then there's a whole wide family of changes, which I'm not going to bug you with because this is the headaches that pathologists have. You shouldn't be subject to them. But we're going to mention some of the features of premalignant changes. And then, of course, the big one, which most breast cancers are, and most breast cancers are adenocarcinomas because the breast is a gland, are the malignant epithelial changes, leading from in situ, which is completely inside the duct, to infiltrating, or just involving the lobule, which is lobular carcinoma in situ, all the way to infiltrating. And then we could talk about sarcomas of the breast as well, just not to leave them out, the malignant stromal ones. Next one. Okay, so, probably nowadays, it's more and more likely that something suspicious is picked up on the mammogram. Classically, you teach the women how to palpate, their breasts and look for masses, and that's really nice. But probably the reason why we've had a lot of success in dealing with this disease over the last couple generations, has been the introduction of mammography. As you know, generally life. So you could probably think of it ideally as the pap smear of the breast. Whether it should be used, routinely might be a little bit debatable, but a nipple discharge is another factor. Pain could be a factor, but it's not specific. An inflammatory lesion of the breast that's benign is more likely to be painful, than the world's worst cancer. Next one. So, what do we generally talk about with the benign epithelial proliferations? Well, we either call them totally benign, or we say they're benign, but there's a statistical association that has a higher relationship to a malignancy, and then we call the ones that are downright atypical, which are the ones which we feel that would probably progress to carcinoma. Okay, the benign ones don't. The so-called proliferative ones have a statistical relationship, but they usually don't. And the atypical ones usually do. Next one. So there's a cyst, and it's a gross specimen. This may be very, very apparent on ultrasound, and it's totally filled with fluid. So what's the likelihood this is a breast cancer? Very, very zilch, right? Very, very low. Next one. Okay, there it is, the same cyst. They can pick up pretty little cysts now, not just ultrasound, but CT. And also you could tell from that cyst that it's totally hollow as well. There's no portion of a papilloma growing inside that breast or anything like that. Next one. There's another cyst. There's the gross specimen. There's the microscopic. The cyst may have a little extra epithelial lining to it, but
What about this?
that looks like a blood vessel to me. Or is it maybe part of a lobule? Well, I'll have to look at the big thing here. It looks like a blood vessel, but I might be wrong. Oh, yeah. If you could see it, or if you had your iPod now, that's the world's most normal blood vessel. Okay, it has a nice little, it might even be an arterial. It's a little squiggly. Next one. Now, if you have some increased in the glandular component, but they look benign and they're not growing in a haphazard fashion, you could call that adenosis. So forget about the picture. Just remember, when your patients have the diagnosis of adenosis in their breast, simple adenosis, it's not regarded as malignant or pre-malignant. Okay, next one. However, if you have the classic fibrocystic disease, and generally most of the total benign breast biopsies in which there's no suspicion of a cancer or atypia will probably be called fibrocystic disease. It's a good term because there's two features. There's fibrosis and there's cysts. You know, so you want to point out some of the cysts? There you go. Those are all cysts. And you want to point out some fibrosis? Well, don't forget, that's a lobule, but probably, yeah, you could probably say that's some fibrosis. Next one. That's the classical definition. Now, what about if that adenosis now, rather than just be calling plain old adenosis, is called sclerosing adenosis? In other words, there's increased in glands, but there's a lot of fibrous tissue. Well, that's worrisome, isn't it? Because now you got these little glands, you got a lot of fibrous tissue, and you go, oh my God, is this infiltrating cancer? But remember one thing about fibrosing adenosis. Even though it may look scary, and there may be a lot of sclerosis, it still conforms to the lobular configuration. Let's see if we got a nice sclerosing adenosis next. Do we? No, that's just the ductal hyperplasia, okay? There's a relatively normal duct. I think that was the inset from the other one, remember? And there's an increased number of cells. So just call it hyperplasia. I'm going to tell you the 2 or 3 key features about ductal hyperplasia that you would worry about being malignant. And that's not one of them. That's just a duct that's filled with an increased number of epithelial cells. Next one. Okay, now take a look at that big lobule on the right. Do you think when you look at the left aspect of that lobule, you see some scar tissue in there? That might be worrisome to a pathologist because they have epithelial structures and fibrous tissue. Oh my God, is that an infiltrating cancer that's going into the fibrous tissue? Well, it might be. But here's the question. Does it still look like a tree? Does it still look like a lobule? So sclerosing adenosis is benign. Now, however, for some reason, the jokers that make up the rules, they have decided that if it's regular adenosis, it's totally benign. And if it's sclerosing adenosis, which is just an adjective, that there's a greater degree of statistical correlation with a malignancy. It's maybe just a small percentage. But, you know, the surgeons like to think, is it benign or is it malignant? And of course the pathologists will say, well, you know, you have to realize that there are these things in between. So this relatively newer classification for, rather than just saying fibrocystic disease benign versus cancer, that you have these things like sclerosing adenosis that are benign, but they have a statistical relationship. Same thing with ductal hyperplasia. That's benign. Hyperplasia is benign, but has a statistical relationship of malignancy. Next one.
It says that the sclerosis can be mistaken for desmoplasia. What's
Yeah. Well, desmoplasia is the process by which cancer, especially adenocarcinoma, when it infiltrates, generates a dense fibrous reaction to it. That's desmoplasia. Do you ever hear the word scarus? They talk about scarus carcinomas. Scarus is like cirrhosis. You know, it's the same root word. It means fibrosis. So a scarus carcinoma is an infiltrating carcinoma that generates a dense fibrous response. That's exactly the same as desmoplastic. It's not specific for breast. Next one. Okay, now this is the scariest one of all, and please, just ignore this one, but these are the kind of things that I have lost sleep over. I'll see something, well, it doesn't really look like a lobule, but there's a lot of fibrosis in there. They don't look like they're trees. And probably, I would say, most pathologists in their lifetime have probably called this cancer at one time or another. And then when they send it out to the consultant, it's called radial scar, which means benign, for such as a pattern of fibrosis that's radial. And there have probably been a lot of women that have lost their breasts unnecessarily because of this. And, you know, it's time for me to go like on about a 1-minute rant. Because, you know, I usually find it very difficult not to use the F word when I talk about malpractice attorneys. But this is not specific for pathology. This is specific for all the medicine you're going to be practicing too. Here's how they do it. Like, you know, if I go to you, you know, Dr. Neal, I got a pain. You're going to examine me, do x-rays, and say, oh, it's nothing. Just go home. It's gas. You know, if I go to Dr. Lauren, she's going to do some tests, and she's going to say, oh, it's a malignancy. You got 3 months to live. Well, you know what you call that? You call it a difference of opinion because you're both well-trained. You're both using good techniques, but it's a difference of opinion. Well, the same thing in pathology. Probably the smarter pathologists I know would call that just a radial scar, but they would also send it to some expert in Harvard to make sure that it agrees with them. I probably called one of those malignant at one time or another in my life. Probably everybody has. So a woman loses her breast unnecessarily. That's pretty bad, isn't it? That's like a lawsuit. So here's what I'm trying to say is, when there's a difference of opinion, the malpractice attorney will go to your partner or that another surgeon that practices down the street, and or better yet, he'll take those slides to Harvard and he'll find somebody that disagrees with you. And then, you know what they're going to say? They say, you didn't practice the standard of care. That's how they do it. Okay, but we're done with our 1-minute rant, so let's go into more. And you don't have to worry about these gruelingly, grisly, difficult breast cases either. Next one. Okay, now, this is so important. Do you remember when I told you that every lobule has both epithelial and myoepithelial cells? So let's say you're looking at that gland over there, and there's some fibrosis around it, and you're going, oh my God, is this cancer, or is this just some fibrous reaction? Well, this is the logical question. If you remember, every cancer, every true neoplasm is a clonal proliferation, right? But let's say that that gland has a mixture of cells. Let's say that that little cell at the tip of the arrow has been shown to be a myoepithelial cell. So here's the question. If it's a gland that has a mixture of cells, epithelial and myoepithelial, is it benign or malignant? It's benign, yeah. Because if it was a malignant infiltrating gland, it would be all epithelial cells. Good point, isn't it? I hope. Next one. Okay. The world's most common breast tumor in the young woman, fibroadenoma. The reason why they're called fibroadenomas is because not only is it increasing the glandular or adeno part, you can see all those little blue irregular things, but you see the fibro part. So the fibro, the stroma, is actually part of the tumor. They're all benign. It is without a doubt the most common solid tumor in a young woman. You know, if you have a friend that's a young woman, she goes, oh yeah, well, you know, they found a little lump in my breast and it looks like it's pretty well defined and it's solid. Well, you know, you already know that's going to be most likely a fibroadenoma. Now, if they don't do surgery and this woman ages, she gets old, do you think they can calcify? Yeah. So when you see these big calcified nodules now in older women, they're fibroadenomas too. Something I should tell you is that how many of you have ever played or bounced a super ball? Okay, we all have. Well, they have the consistency of a Super Bowl, okay, and they're very well defined and round as well. I'm sure every pathologist, including me, has been tempted to just bounce these things on the floor, you know, to diagnose them as a benign fibroadenoma. Of course, if they're calcified, they're probably not going to bounce back, right? Next one. Okay, let's say that the epithelium that lines the duct decides it wants to grow, and not just hyperplasia, but grow in a papillary fashion. So can you have papillomas of the breast then? Yeah. Are most of them benign? Yeah. Could you have a malignant papilloma of the breast? Yeah. Now, the man who wrote the definitive book on breast pathology, his name is Hagenson, he has a rule. He says, never diagnose a papilloma on frozen section, because if the papilloma looks malignant, especially if it's subareolar, you know, close to the surface, which of course it more likely be because that's where the big dilated breast ducts are, you may discover the next morning that it's really benign. So a lot of women, I know pathologists, you know, that have, you know, gotten sued successfully because they made the mistake of calling a papillary lesion on the breast malignant on a frozen section. That's like the #1 rule. Next one. But do you see why it's a papilloma, by the way? We already talked about papillomas in the ovary and papillomas, you know, in the in the lower urinary tract. It's papilloma. Go back to the big high power thing, the next one. Yeah, fingers, right? Connective tissue on the inside, epithelium on the outside. Fingers, that's the definition of papilloma. Next one. There's another papilloma. And can I give you another little, if you're agonizing whether a papilloma is benign or malignant, it's probably benign. And you don't have to really agonize now. You know, you just get another opinion. You send it to the guy that is well recognized at Harvard as being the world's most leading breast pathologist, and he agrees with you, and then your surgeon thinks you're so smart. Next one. Okay, I guess it's about time we talked about the atypical ones now, isn't it? Or did we already talk about atypical? So let's see what's next. Now we know we can have hyperplasia of a duct. We know we can have papilloma. We've seen examples. We know that we can have a lot of things that are totally benign. We know we can have apocrine metaplasia. You know, that's benign. But what are the changes of cells growing inside of a duct that make you think it's either malignant or very much pre-malignant? Now, if they're malignant, but they're limited to the duct, that's what you call DCIS, isn't it? Ductal carcinoma in situ. But there's a whole wide variety of changes that we agonize over, and I'm just going to mention a few of these. Well, let's say that you see breast lobules, and you know, remember in all those lobules that Mario showed, they were still like a little bit of fibrous tissue between each one? Well, if that's completely lost and these little gland strictures are totally back to back, that's a feature. It doesn't mean it's malignant. Let's say that you have increasing growth of cells in the duct, but now you have little holes between these cells. It looks like Swiss cheese. It's what they call Swiss cheese hyperplasia, or crib reforming. That's an atypical feature as well. What about, you know, we're finally getting down to the nuclei. What about cells that, you know, are pleomorphic and big and, you know, have a mitosis going in 3 or 4 directions? Those are atypical from the point of view of looking at the nucleus. But in general, malignant breast cells often do not have a tremendous amount of pleomorphism and hyperchromasia. Increased number of mitoses, yeah, it means the more mitoses you see, the faster it's growing. Faster it's growing, the more likely it is to be malignant rather than benign. Okay. Roman bridges, very, very, very suspicious. However, the single most important feature in a duct that points that it may be malignant or very much pre-malignant or downright ductal carcinoma in situ is a very simple concept. It's necrosis. Now, do you remember when we talked about prostate, we said nucleoli was the most important thing? Remember we talked about smooth muscle tumors, we said mitoses were the most important thing? Well, when it comes to intraductal breast lesion, the big thing that makes you almost sure it's malignant is true necrosis. Now, do you remember, I don't know, the radiologist will use the word stippled calcifications. Okay, so that means he's looking at a breast on a mammogram. There's not really a mass, but he sees a little clustered of stippled calcifications inside of ducts. Do you think that calcification came from nowhere, or do you think they're the result of necrotic ductal cells? So there's a good correlation between stippled intraductal calcifications. But can he see necrosis? No. Only the pathologist can see necrosis. So of all the things there, I would probably put this as a test question if those jokers on the board allowed me to give real questions rather than these stupid clinical scenarios. So if you were to say, what of these is the most important feature? It's the one that has 3 asterisks after it. It's necrosis. If it's necrotic, it's sometimes called comedocarcinoma. You know what a comedo is? It's a zit. Did you ever pop one of your zits when you're a teenager? What comes out of that little duct? Okay, it's necrotic junk. Okay, that's why they call these comedocarcinomas. Next one. Okay, so there's a normal duct in the northwest. There's a normal acinus over there. There is a duct down there that's filled with cells, but she's little spaces between them. Does that remind you of Swiss cheese? They also call it cribriforming. And yeah, in the southeast, that's atypical hyperplasia, that's cribriforming, that's Swiss cheese. And look do you see that even though those ductal cells are kind of growing and there's holes in them, you don't see any fibrous tissue, do you? And of course, the one on the lower right in Florida, southeast, you can say that those are a lobule now. I shouldn't do this because it's going to blow your mind, but do you remember in all the lobules we saw, like the one up there on the northeast, there was also a nice little lumen in the middle? But what if there's some increased cells growing in that acinus where it almost obstruct the lumen? That would be called hyperplasia. It's not malignant, but think about it. You have an acinus, and for some reason, estrogenic or not, or neoplastic or pre-neoplastic, you've got to increase the number of cells in that acinus. It's going to make the lumen look smaller, isn't it? Next one. There you go. We've been beating around the bush. Take a look. Oh, I hope you can see the little calcifications on the thing there. Yeah, I could see them even from here. Yeah, you can see them much better here, but do you see the calcifications on the mammogram? Yeah, that's the best one. There's also a smaller one above it. That's suspicious, and you look. Here, let's make this very simple. Let's make this very, very simple. You look at a duct, and there's truly coagulative necrotic crud on the inside of it. That's cancer until proven otherwise. That's lobular carcinoma. That's ductal carcinoma in situ. So you feel great because you've diagnosed ductal carcinoma in situ. But you look at more sections and you go, well, you know, there's also a little bit of those cells that are infiltrating into the stroma too. Then we're in a whole different category. Ductal carcinoma in situ does not metastasize, does it? Any infiltrating carcinoma technically can. Do you think that you'll ever find positive lymph nodes in a ductal carcinoma in situ? No. Well, there have been some reports that say, oh yeah, well, sometimes 1%. Well, if it's 1%, it means that there was probably an area of infiltration that they missed when they look at the slides. Okay, next one. Ductal carcinoma in situ. Maybe not a lot of necrosis, but some hyperplasia there on the left, cribriforming. And I don't know, can I maybe make a case for early necrosis there on the right? No, but I'll certainly make a case for some cellular atypia. Okay, you can see some of those nuclei on the right are bigger and darker, but that's not the prime thing. It's necrosis, necrosis, necrosis. Next one. ductal carcinoma in situ. Now, in this case, I think you'll agree there are a lot of nuclear abnormalities. There's a lot of variation in size. There's a lot of variation in shape. But it's all limited to the basement membrane of the duct, isn't it? So if you found another area on this slide or in this patient that was actually infiltrating and causing a little fibrous response, you know, these kinds of cells, you wouldn't care about in situ anymore. You would just have to call it by its worst component, which is infiltrating. Next one. Necrosis, necrosis, necrosis. You want to find tiny microscopic calcifications, or do you want me to help you? I see mostly necrosis. I don't see much by way of a lot of calcifications there. Oh, I don't know. I call them microcalcifications. This necrotic crud may calcify eventually, but right now, some of those little dark blue things, they may be microcalcifications or just dead nuclei.
The whole thing, or just this?
Just the little stippled areas in there. And also, some of those may be microcalcifications. Can't say. Got to be honest. Next one. Now, you know that what they're doing now is when a radiologist does see an area suspicious for, you know, stippled calcifications, and they do the biopsy, first of all, they want to make sure that the surgeon got it because it's probably a non-palpable mass. And then they take the X-ray specimen to pathology, and they put it on a grid, you know, ABC, 1, 2, 3, and then they X-ray it. So the pathologist knows if those stippled calcifications are in grid, you know, C4, that's where he wants to do most of the slides from, because you can't do slides on everything on a breast biopsy. So you know what quadrants you would concentrate on if you wanted to examine these. It's the one that contained the mass. And this is most likely a non-palpable mass. Next one. That's a Roman bridge. I actually saw one in China. The Romans never came to China, but do you see there's a certain configuration? This is also something that's very, very, very highly suspicious for a ductal carcinoma as well. Let me show you a Roman bridge. Now wait, before you go to the next one, just to kind of memorize that Roman bridge pattern. Okay, now go to the next slide. Show me the Roman bridge. Yeah, isn't that cool? It's nothing but pure epithelial cells forming a little bridge. That's a Roman bridge. Next one. There's a normal lobule again, isn't it? And take a look. Remember, the acini all have tiny little lumens. Maybe it's only 1 or 2 layers of cells. Next one. But what would you call those lobules? You know, the acini just loaded with it. That's lobular carcinoma in situ. Whenever the lobules are so packed that they no longer look lobular, they just look like these big blue balls. Now, lobular carcinoma in situ is the analog to ductal carcinoma in situ. There's some debate as to whether they really arise from the terminal ducts or the lobules, but let's call it what everybody else has called it, lobular carcinoma in situ. And what do you think has a much, much, much worse prognosis? Lobular carcinoma in situ or ductal carcinoma in situ? Ductal. Generally, lobular carcinoma in situ as a biologic behavior goes on for years and years and years and usually never turns into cancer. That's a general rule. Now, some of them do. That's the problem. So it's not unusual. And they're not palpable masses either. So it's not unusual when a surgeon does a breast biopsy for whatever reason, and you see lobular carcinoma in situ. They're probably not going to rush and do the mastectomy and all that stuff. Sometimes the best treatment for that kind of patient is what we call judicious neglect. Something to just keep an eye on. And I know a woman's going to feel terrible. Well, the pathology report says carcinoma, but here I am still walking around and the surgeon doesn't want to take it off. Well, that's probably the best management is judicious neglect. Now that we established that the lobulars are much, 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 much benign carcinomas than the ductal carcinomas in situ, let me ask the next question. If the lobular carcinoma in situ infiltrates, do you think it's a lot worse than the ductals? Yeah, it is. That's kind of ironic, isn't it? The in situ portion is much, much, much more benign, but if these infiltrate, it's much, much worse. But they probably are not going to infiltrate. Now, the cool thing is, from a diagnostic point of view, is if they do infiltrate, they infiltrate in a certain pattern called the Indian file. In other words, when we look at the infiltrating carcinomas, there's glands growing in every which directions and they're big cells. But when a lobular carcinoma infiltrates to become infiltrating lobular carcinoma, these cells grow in straight files. Like people, I don't know how it got the name. There's a little bit of debate as to how the term Indian file. Some people say it was American Indians. Some people say it was Asian Indians. But if you remember from watching a lot of these cowboy movies, how sometimes when the Indians went on their patrols, they were in single file. You know, and there's like 10 of them, but they're all walking in single file. Well, that's what the Indian file is. It should be called single file rather than Indian file. Next one. That's lobular carcinoma in situ. Take a quick memory picture. Next one. It usually hangs around many, many, many years. Judicious neglect is what I said. Whether I remember that or not, I don't know. But if it infiltrates, it's worse than the lobular, and it almost always infiltrates in this so-called Indian file pattern. Next one. Okay. We'll show a picture of that somewhere along the line, but it wouldn't be fair if we didn't talk about things like causes and risk factors and, you know, ultimate causes. You know, there's a lot of, you know, we talked about neoplasm. We'll talk about genetic gene mutations in the breast cancer gene and all that stuff. But what about from overall risk factors? Well, age, right? Older woman, more likely to get breast cancer than a younger woman, right? If you have your first period at a very early age, that's a risk factor in early menarche. A first live birth at an early age, that's a risk factor. Even if you don't get into the BRCA gene and the P53 and all these things that might affect many cancers. What about if you just happen to have relatives with breast cancer? The closer they are to you genetically, the bigger your risk factor. I think maybe somebody here knows the statistic. I might be wrong. But you know what the chance is nowadays in America of any woman getting a breast cancer? It's like incredibly high. I'm thinking 1 in 6, okay? It's definitely less than 1 in 10. It's a high risk. It's a #1 incidence of cancer. What about race? Caucasians are more at risk than blacks. Now, what about the history of many breast biopsies? That's interesting. Breast biopsies don't cause cancer, okay? But I think the inference here is that if a woman has multiple breast biopsies, there must be a reason for that, you know? And perhaps some of the reasons is that there were changes going on that may predispose. So that's why they said breast biopsies, not as a cause, but just a statistical relationship. Well, estrogen, exposure. You know, people that are on hormone replacement therapy or, you know, osteoporosis, they're going to say, well, as my risk for, you know, breast cancer increased. And well, what does estrogen do? You know, you're going to have the drug salesman coming around and they're going to say, oh, yeah, well, you know, this has no risk and we did this, you know, billion-dollar study. Here, let's be very simple. What proliferates breast tissue? Estrogen. Estrogen doesn't cause breast cancer. But remember, in cancer, in carcinogenesis, you need both a carcinogen, which we call an initiator, and then a hyperplastic influence called a promoter. Well, estrogen's a promoter, isn't it? Did you want to say something?
Yeah, you made a comment about the first live birth being a risk factor.
Yeah.
But you said younger age, and I wanted to.
Okay, did I screw that up?
I think it's supposed to be older age.
Okay, you know what? I'll default to you. I was kind of thinking about it when I said it, but if you're sure, we'll default to older age. Okay, thank you. I really love it when people prove me stupid. I'm kidding. Okay. What about radiation exposure? Well, radiation is a cancer factor for anything, isn't it? Okay, mutations. Carcinoma of the contralateral breast or endometrium. What does it mean if a woman has a carcinoma in the right breast? Do you think her chances of developing on the other side are significantly greater than somebody that never had carcinoma anywhere? Yeah. High fat diet. The two cancers in which fat diet and obesity are the highest related are both these sex-specific cancers. It's prostate for men and breast for women. High fat diet is a risk factor. Geographic influence, I don't know what that means. Obesity, of course, related to the high fat. Exercise or lack of exercise, that's probably true with everything. Lack of breastfeeding is a risk factor. Women that breastfeed have a lower incidence of breast cancer. There's a list of environmental toxins. Tobacco is a big thing. And let me mention one more thing. No textbook will ever tell you this. I know the woman that is the president of the ABC Foundation. It's called Abortion Breast Cancer. Women that have had multiple elective abortions have a higher risk of breast cancer. For some reason, there's a lot of political reasons why this fact isn't published. But I told her when I give the talk on breast cancer, I've seen the literature, that's a risk factor as well. And even though we said tobacco was really, really high on the list for things like lung and for like the things like kidney, it's also a significant but not as high for breast as well. So these are all the risk factors. Next one. Let's talk about the staging. And there's a whole big TNM stage that you could memorize, and maybe somewhere along the line you'll see somebody with a T2N1, blah, blah, blah. But just think again about the biologic behavior of breast cancer. It's in situ, which means either in the duct or in the lobule. At some point in time, it may infiltrate. If it metastasizes outside the breast, the first place it's probably going to go is whichever lymph node happens to be draining based on the geographic location, axillary, supraclavicular, or internal thoracic. It may involve the chest wall. It may invade into the pectoralis. So these are all the biologic behavior, and the little numbers that you have for the TNM system are reflective of that. And all of these staging numbers are all prognostic, not only prognostically related, but determine the type of therapy. And the general trend, because of the nature of like estrogen positive breast cancers being responsive to tamoxifen. So even a person that has absolutely no evidence whatsoever of nodal metastases may go on a chemo that's estrogen receptor positive. It'll respond to tamoxifen like compounds. HER2, the genetic test, HER2 new, sometimes it's called, a very, very, very big prognostic lab test. Positive HER2 new, not good. Okay, we said that ERPRA, very, very good. If there are estrogen receptors in the nucleus, it's more likely to respond, so everything else being equal. And remember, tamoxifen is a relatively non-toxic chemo, isn't it? Okay, next one. Okay, so here's our biologic behavior. In situ, early disruption of the basement membrane, stromal infiltration, lymphatic vessels, sentinel lymph node metastases, more lymph node metastases, perhaps involvement of the adjacent structures, in which case we saw an inflammatory carcinoma, but it could be infiltration of the bone or the muscle. And then, what happens after that basically can go anywhere. And remember, breast is one of the 4 types of cancer that usually goes quickly to the bone, just like with prostate, just like with renal, and just like with thyroid. Next one. We'll ignore this, but this has probably changed because this is how breast cancers present. As you can see, most of them there were invasive, but there's a growing number of in situ carcinomas because of better mammographic techniques. I don't know, there are probably certain recommendations for women whether they should get, mammograms, every so often. Maybe, I don't know how to determine this, but certainly if there's a lot of risk factors present, that might be a good idea, routine mammography. Next one. Okay, let's just give you a couple histologic tidbits. Is that even though your run-of-the-mill breast cancer is an infiltrating ductal carcinoma, rather than an in situ ductal or infiltrating or in situ lobular. There's a couple of variants which you might see on your pathology reports, which means even though it's an infiltrating ductal, statistically, for some reason, which we could theorize about, it'll probably be a little bit better prognosis than your run-of-the-mill infiltrating ductal. And one of them is tubular carcinoma, which are very, very, very hard to diagnose because they look a lot like normal glands. In fact, a tubular carcinoma might be diagnosed like as one of those glands in which you can't find myoepithelial cells. They're very difficult to diagnose. Most people I know would never want to diagnose them without a consult. Or if there's a lot of mucinous tissue, they call these colloid carcinomas. They're usually in older women. Mucinous tissue is a good factor. They're generally going to behave better than any other run-of-the-mill infiltrating ductal. Or medullary carcinoma, which are surrounded by a lot of lymphocytes. Now that one makes sense because the more lymphocytes or immune cells you have surrounding a neoplasm, you think, well, the more this body is trying to fight the neoplasm. So that's the explanation for the medullary carcinomas, as long as the mucinous and tubular looking pretty good as well. Next one. There's your run-of-the-mill infiltrating ductal. Mario, I know you could do this. I want you to delineate precisely the irregular boundary of that big infiltrating nest of infiltrating glands, right there in the middle of the field. Yeah, I want you to drive right along the edge of the cells. Yeah, and everything around that is stroma, isn't it? This is evoking a desmoplastic response. It's an irregular gland. And in addition, we have the benefit of seeing considerable pleomorphism and hyperchromasia as well, which you don't always see. That's your run-of-the-mill infiltrating ductal. You can take a quick picture of that, but in all honesty, if I told you that was an infiltrating carcinoma of the prostate or infiltrating adenocarcinoma of the breast or infiltrating adenocarcinoma of the pancreas or any other glandular thing, even thyroid, would you say, well, yeah, I guess it could be? Yeah, you could. So don't think that there's anything about that at all which is specific for breast. Actually, there are a couple of things, but we're not going to mention them. Next one. Now, what do you call that? So is infiltrating lobular or infiltrating ductal? Yeah, those are the Indians marching along the banks of the river, getting ready to invade, General Custer or whatever. Yeah, there you go. And they're small cells, aren't they? You could be fooled by them. They look like lymphocytes, but the fact that they're linearly infiltrating, that's a bad sign. Next one. There you go. Now, in this case, they're not Indians. They're British soldiers. Maybe that's the way they marched when they were in India. I don't know. I don't think any. I've tried to look up the truth behind Indian file, and I get so many confusing stories. If somebody ever really finds out the truth, will they let me know? Next one. Okay, that's what they call the tubular pattern, or well differentiated, and they're not really conforming to a lobular configuration, but they don't look grossly bad either. So let's say that because somebody from Harvard called that a carcinoma, a well differentiated, or tubular is another name. And now you got your microscope and you're looking at all those glands and you're looking for even one myoepithelial cell. Well, you're probably not going to find it, right? Next one. What's that surrounding the glands? A lot of mucin. Can you tell? Myxoid, mucinous type material. That's a colloid carcinoma. It's also a relatively well behaving infiltrating ductal carcinoma. Yeah, point to the grayish yucky stuff. I learned one word in Spanish when I was here. It's called gelatinoso. And that's basically the gray stuff surrounding those tumor nests. It's producing mucin. If you had a muci-carmine stain, that gray stuff would be quite red, wouldn't it? Next one. That's why they call it carmine, muci-carmine. Carmine is red. This is the so-called medullary pattern. And I think you can absolutely put your pointer, for the benefit of the buzzards, to see that nice cluster of epithelial cells. But what is everything else surrounding it? Yeah, there's one. Do you see the junction basically between the lymphocytes and the tumor cells? That means those lymphocytes are working pretty hard to battle that. That means it's one of the better prognosis in general. And I know somebody say, oh, well, I know a young woman that had a medullary and, she was gone in 3 months, I'm just talking about general statistics. Next one. Okay, we're going to say a couple quick words. We already talked about a fibroadenoma as being a benign tumor in which there's both neoplastic aspect to the stroma as well as the epithelium. But you can also have another type of more giant fibroadenoma, and it's benign. And the problem is this tumor was called cystosarcoma phalloides. So I think, well, if it's called sarcoma, it must be malignant. No, the cystosarcoma phalloides are benign. That's why they're generally more named now just phalloides tumor. They don't want to put the word sarcoma into something that's not a sarcoma. Next one. And does that look like a fibroadenoma, only it's bigger and it kind of has more kind of a gelatinous degeneration in the stroma? That's a cystosarcoma phalloides. They're benign. Or actually, I'm sorry, that is a fibroadenoma. I couldn't tell the difference. Next one. Okay, the last thing we're going to say is about male breast. For every 100 carcinomas of the female breast, you have about a male breast. And not surprising, there's often some kind of estrogenic influence. And you know that there are also studies have been done that show that there are certain drug relationships to gynecomastia. It's not malignant, but men do get carcinomas of the breast. Okay, let's look at the next slide. Now, do you see those look like almost like terminal ducts? Even though you may have gynecomastia and the men's breast may be enlarged, when you actually look at the tissue, you don't have really, really true development of the lobules. Those kind of look like endings of blunt ducts. Next one. Oh, that's it. Okay, we've probably taken a lot more than an hour here. Anybody know the time? Okay, so we said we're going to probably not keep you more than 2 hours. So here's what we'll do. We'll take a break, and all of those slides that I spent hours looking at yesterday for lab, I'll probably narrow down to like 1 or 2 slides per section. And I'll keep in mind to show you the stuff that I kind of remember that I think, the USMLE thought were important. I can't show everything. So let's take a 10-minute break, and then we'll go to histopathology lab, and you don't have to worry about using that anymore because I'll be sitting at the microscope there at the podium. See you in 10 minutes, folks, and probably play 2 or 3 songs in between. Oh, you want to do that? Oh, great. You want to do it here? Yep. Good. Can you do the one after that as well? Could we do 3 of them? It came out really good yesterday. You got a lot of songs in there?
Couple, yeah.
Oh, that's it.
está en nuestro poder. Yo no sé lo que es eterno, no me pidas algo que es del tiempo. Yo no sé mañana, yo no sé mañana si estaremos juntos, si se acaba el mundo. Yo no sé si soy para ti, si serás para mí, si lleguemos a amarnos, odiarnos. Yo no sé mañana, yo no sé mañana quién va a estar aquí. De un café pasamos al sofá, de un botón a todo lo demás. No pusimos reglas ni reloj, aquí estamos solos tú y yo. Todo lo que ves es lo que soy, no me pidas más de lo que doy. No, yo no sé mañana, yo no sé mañana si estaremos juntos, si se acaba el mundo. Yo no sé si soy para ti, si serás para mí, si lleguemos a amarnos, odiarnos. Yo no sé mañana, yo no sé mañana quién va a estar aquí. Esta vida es igual que un libro, cada página es un día vivido. No tratemos de correr antes de hablar, esta noche estamos vivos, solo este momento es realidad. No, no, no sé. Oh. Yo no sé mañana, esta vida es una ruleta que gira sin parar. Yo no sé si tú, yo no sé si yo, cómo será el final. Puede ser peor o puede ser mejor. Deja que el corazón decida, vida mía, lo que sentimos. Mañana, yo no sé. Ahora lo que vivimos es algo realmente lindo. ¿Quién puede saber lo que pasará? Mañana no hay nada escrito. No sé, mañana estamos solos tú y yo. Y los momentos hay que vivirlos, hay que vivirlos. Yo no sé mañana, yo no sé mañana si estaremos juntos, si se acaba el mundo. Yo no sé si soy para ti, si serás para mí.
Can I rely on you to bring in a ton of music? Or do you want me to download?
See, I just came back from Ghana, and I want to share the stuff that everyone was doing over there. So QB tried to show me how to do it. He sat me down in this place, and he said to me, nobody wanna see you rising, and when they do, they don't even like it. They just wanna see you deep in crisis. Drive yourself, you don't need a license. Holler her, she can even ride it. Go ahead with your feet just like this. Then he showed me the latest. Go walk over the pages. Now what you do, man, you're so dope. I'm so dope, I'm so dope. Now watch me do my so dope. I'm so dope, I'm so dope. Now watch me do my so dope. I'm so dope, I'm so dope. Now watch me do my so dope. I'm so dope. You walk over the pages. Now what you do, man, you're so dope, so dope, so dope. I'm 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 so dope, so dope, so dope. You walk over the pages. Now what you do, man, you all wanna learn how to do this. So I'ma take you right through this. I thought the dance is the movement. So when you jump on the floor, better use it. First step is a step, step. You can move to the right, to the left, left. You can even freestyle when you step, step. Put your hands in the air, did you rep, rep. So go, go, go. Twist your fingers, you can wave and say hello, blow, blow. Make a fist and you can hit them with a blow, blow, blow. No balance, that's how you do it. So, let me see you go, go. QB taught me this. Nobody wanna see you rising, and when they do, they don't even like. They just wanna see you deep in crisis. Drive yourself, you don't need a license. Holler her, she can even right there. Go ahead with your feet just like this. Then he showed me the latest. Walk over the pages. Now what you do, man, Azoto, Azoto, Azoto. Now watch me do my Azoto, Azoto, Azoto. Now watch me do my Azoto, Azoto, Azoto. Now watch me do my Azoto, Azoto. You walk over the pages. Now what you do, man,
sorry, sa Azonto. Oh, wait, yo, yo. Ain't man, you go slow. Yeah, when you not to blow. Move to the rhythm, here we go. I'll show you how to do this. So, some inside, make a sound. Up across on the south side. Move to the left and right and watch me free. Azonto. All my ladies try to pose and free. Drop it low and make the boys say, damn. Go some more. Freestyle it the way you want to say. Chimo.
now watch me do my Azoto, Azoto, Azoto. Now watch me do my Azoto, Azoto, Azoto. Now watch me do my Azoto, Azoto. You walk
Yeah,
over the
30
page.
seconds.
What you do, man, your head, shoulders, knees and toes free.
Azonto. Yeah, shashiwo, free.
Azoto, migrants gang, man, I like your show me.
Azonto. A day, zingolo.
Check this out, yo. Head, shoulders, knees and toes free.
Azonto. Yeah, shashiwo, free.
30 seconds.
Migrants gang, man, I like your show me.
Azonto. A day, zingolo. Azonto.
Okay, we're done with the break. We're back for maybe another half hour, hopefully not too much more. And we're going to go to lab now. And I know this doesn't look like a lab. I know it looks like a lecture hall. You don't smell formalin or see microscopes around. But I probably overdid it. I always overdo it. I picked out like maybe 20 or 30 slides on male, female, and breast. And I thought, well, they should have a good example of all this. But we've shown a lot of histopathology already, but we are going to show a few slides. Now, but the big thought I got during the break, because I always have like a thought during the break, there's something I should have said is, I know that the people online really, really not only appreciate the histopathology labs, but it's a lot of fun too. You're going to see the more labs we have, it's more fun. But I'm dealing with an attitude now in medical education in which they've kind of moved away from histopathology. And I know some of the students here are saying, why should we have to look at slides? We're not pathology residents. And I also know a couple of you have asked me, well, are they going to show a lot of slides on the exam? And I say, no. But this is my rationale. I'm an old-fashioned guy, and I firmly believe that the best way to understand a disease, you could read PowerPoints and bullets in that, but I think the very best way to understand a disease is to actually see it. So when you're talking to one of your consultants about a woman who has, ductal carcinoma in situ, you remember seeing it. You remember seeing the necrosis. You remember seeing the calcifications, maybe the Swiss cheese and so forth. So there's nothing that's going to make me abandon the labs. And so we're going to have a little lab now. And I know I have a nice remote mouse here. Usually when the pathologist is looking at a microscope, he's sitting down. So I have a hard time. Does somebody have a flat surface for me, like a pad or something? Yeah, but that's not a good surface for the mouse, is it?
Well, that's the one I was using.
Oh, it is? It's pretty good then? Okay, well, in the labs, we turn off the lights. So, we can see the microscope better. And we go through the routine. We've been through this so many times. And I'm pretty sure that this is going to work here. So let's see if we could get it to work. Okay, I'm looking through my microscope and I'm not getting eye strain. And we're going to somehow try to drop this thing down. Whoops. Yeah, there you go. Oh, you know what? You want to know the problem is I really can't see that too well. I think I'm going to be standing up rather than sitting down. Okay, we're in lab. And you see all these things here? These are our slides. I've already made sure that our microscope is configured. It looks like I picked out about maybe 20 of them or so, but we're probably going to have to narrow it down now to maybe 5 or 6 or 7 of what I have to decide are the most important things for you to see. Now, the one thing that you're all going to see, whether you like it or not, is normal. You're going to see normal testis. You're going to see normal penis. You're going to see normal ovary, normal prostate, normal breast. It's so important because if you can visualize that, then we can talk about the patterns of variations from this normal that are indicative of what we call diseases. So let's start out with, I see a bunch of them at top, alphabetical, our breast. And actually, I don't really see a normal breast here. I thought I had one, but let's do the easy ones. Okay, some of these may be sort of slam dunk, recognitions. What is this? It's a very well-defined nodule. It's a tumor. It has a lot of connective tissue, and it has some generally, irregular glands, but the whole thing is very well-defined. This is something that you might think is basically a rubbery fibrous tissue component. Oh, I'm seeing a bunch of our students online have already jumped the gun and given you the answer. But it is a classical fibroadenoma, most common breast tumor in young women. What percentage of the cross-sectional area here is fibrous tissue? Well, way more than half, maybe 70, 80%. And what percentage of it is adenoma, or these little glands? Now, in the older days, sometimes, and even I know in some of the medical schools, they teach the difference between a intracanalicular and pericanalicular. I don't think that matters because there's no prognostic difference there. So let's just say it's a well-defined tumor. You might even say that the edge of it here has sort of a fibrous-like capsule, has the consistency of a rubbery superball, and is the most common solid tumor of the breast in young women. There's really nothing more to say about it, but I can appreciate the comments that I'm seeing along there as well. So let's close this one up. And, you know what? We didn't say we had a normal breast here, but I want to show you something. This is in a way, it's kind of normal. This is a normal pregnancy or lactating breast, isn't it? And we showed this picture before, and now we could even zoom in on it. So even though, there's a lot of, epithelial cells there, when you zoom in on the whole thing, like, you can still make out the configurations of nice, well-formed lobules. Some of those have a good amount of secretion in them, but not to the point where the lobules are distended like they look like thyroid. So no matter what this is called, I'm inclined to think this is a breast of pregnancy or late pregnancy. In a lactational breast, for example, probably most of the acini might look like this. Almost looks like a thyroid follicle, doesn't it? Okay. Another thing I want to point out as a feature of benignness, other than the fact that it conforms to the lobular configuration, is that even though there's an awful lot of proliferation of these glands here, I'm going to zoom in on that one area. You notice how every acinus, like this one here, you notice it's still well separated from surrounding, acini. They don't fuse like they do, with cribriforming or Swiss cheese hyperplasia. This is like another feature of benign. Now, you want to know another thing I'm going to do for you? And I think I'm pretty sure at this point, these are all acinar or epithelial cells here, correct? Well, what would you might be inclined to call this kind of a peripheral flatter cell? Maybe here, or maybe here, or maybe here, or maybe here. Those are like probably myoepithelial cells, aren't they? So every normal benign should both have a mixture of both acinar as well as, or epithelial as well as myoepithelial. And I kind of like doing this lab because I could look at some of the comments when I throw out the questions, and then, you know, some of the bolder people venture their answers, and they're almost always correct. Now, you know what? I threw this particular case in because it's something that we didn't talk about, so I felt a little guilty. We didn't talk about, because some people might call this a skin disease rather than a breast disease, but this is a disease that's pretty unique to the skin of the breast, or the areolar, or the nipple area. A woman comes in with a crusty, scaly nipple lesion, okay? The big concern is a disease called Paget's disease. Somebody actually mentioned it over there. Now, take a look at the portion of skin over here, in which I'm going to blow up in a second. And we got the little box there in South Carolina. Look at that's normal sort of skin, isn't it? You got a nice sort of palisaded stratum bassalis or germinative. I'm getting a little flatter, finally a little stratum corneum. Maybe you can even find some skin appendages there, but you know, you're probably not likely to see hair. You might see, you know, some eccrine sweat glands. But look, as you get a little bit more progressing towards this crusty area, you're starting to see a few cells there near the stratum germinativum that look like they're a little bit fatter and more ballooned. And you might not be too convinced now, but if I move a little bit more towards the area, which I am, you're going to see a whole bunch of cells here now, and we're going to see more and more, and I'm going to find some classical ones. There's one. You see, it looks like a nice round cell. You know, there's a cell that has a mitosis. So you're worried that maybe this is some kind of neoplastic proliferation of the skin of the nipple. This is Paget's disease, okay? It's not Paget's disease of bone. It's Paget's disease of nipple. They're spelled the same way. And in this one, you see these ballooned cells. They would almost look like where the melanocytes are supposed to be, except they don't have melanin. But here, I'm going to blow this one area up, and I'm going to point out a classical Paget cell for you, even though there's a lot of them. Well, that didn't want me to go that high. There's a Paget cell. There's a Paget cell. There's a Paget cell. This is Paget's disease. So what does that mean? There is an extremely high association between this crusty nipple lesion and deeper infiltrating carcinomas, not just of the breast, but even like deeper organs. So this is a very serious disease. Yeah, it could be cured probably just by a local skin excision, which of course they don't. But remember, when you have a patient with Paget's disease of the nipple, their chances of having an underlying infiltrating malignancy of the breast as well as other areas is pretty high. And these are classical Paget-looking cells. Okay, I have not been looking at the buzzard comments there, but I'm going to start looking at them more. Okay, let's move into, oh, you know what? I really do have to show you the world's most normal cervix. So if you know that this slide is labeled CXNL, you know what that means. Well, here's a cervix, and you know all these little things are glands, and they're probably filled with mucin. And look at, here you have nice columnar epithelium. So you know this is the columnar portion of the squamo-columnar junction. And you could tell that's mucin. Okay, they look like the mucinous cells. We're looking at the mucinous tumors of the ovary. They're just, if you did a mucicarmin, they'd be as red as hell. And now we're going to move along a little bit. And you see some more glandular looking cells here on the surface, and then you see straighter things. Now, you know, this is beautiful. You want to know why? Because usually when they talk about a squamo-columnar junction, it's kind of a philosophical concept. Very rarely do you get a chance to see where the last squamous cell meets the first columnar cell. And remember, it's not always straight, and there's always a lot of skip areas, just like in the other squamo-columnar junctions. And very often, well, we won't talk about metaplasia, but let's just say if they had to give a prize for the world's most normal squamo-columnar junction, this would be it. Because these are all classical squamous cells, you know, multi-layered or stratified. They don't really flatten out that much. They certainly don't keratinize. And these are classical columnar mucosal cells here. What's that? Well, ideally, yeah. And sometimes that's visualized. And yeah, I think we showed a picture of, this will look grossly like it's kind of a whitish kind of a sheet. And this will look very mucinous. And sometimes you can see sort of a line. It's never a perfectly round line. So that's where they generally would like to take their pap smears. But what else is there to say about the squamo-columnar junction classically? It's a growth area, isn't it? So where do you think most of the carcinomas, the squamous cell carcinomas of the cervix or dysplastic changes arise from? This part of the squamous, this part of the columnar, or the squamo-columnar growth zone. So this is the area where theoretically the squamous cell carcinomas arise from, classically. Okay, so much for that one. Let's move into, I got to show you a couple things. Now see, it's very hard to show you what I would call like a normal endometrium. Because what is a normal endometrium? You know, there's a proliferative endometrium, a secretory one, a postmenopausal one, a hyperplastic one. You know, but like, what is a normal endometrium? Well, for a premenopausal woman, a normal endometrium is either a proliferative or a secretory or a menstrual, remember? The menstrual is the first few days, 3 or 4 days, and then up until ovulation you have these changes which are called proliferative, primarily under the effect of estrogen. And then once that ovulation starts and you got some more progesterone coming in, you then have these secretory changes. So I'm going to show you an endometrium logically that we'll call proliferative. Now, see, you all know this is myometrium, don't you? Because it's just smooth muscle bundles and arteries. And now you can see some surface glands, okay? And you can see the actual glands. And the connective tissue between the glands is not smooth muscle like you see out here, but it's a specialized kind of connective tissue called endometrial stroma, you know. And those are it's the stromal cells under the influence of progesterone, you know, that become decidua as a buffer zone between the placenta and the uterus. So let's quit talking and actually show some pictures here because we're in lab. Let's look at these glands. Okay, now, even though there's a lot of subtle changes, and I can tell you, especially in the secretory phase, a good pathologist can not only tell you that she's ovulated, if it's secretory, but she could probably tell you how many days after ovulation it is, up to about 14, of course. But we don't care about those subtle changes. Let's just ask ourselves this question. Are there vacuoles in the columnar cells, or is there secretion material? And of course the answer is no. But does that make it proliferative? Well, not really. What makes it proliferative is realizing that this endometrium is growing under the influence of estrogen, is that you're going to find mitotic figures, normal mitotic figures, in both the glands and the stroma. Now, that could very well be a mitotic figure, and there's a mitotic figure, and you would never see mitoses or very, very rarely in secretory glands because they're done growing. They want to secrete now. So this is the world's most classical proliferative or pre-ovulatory or estrogenic endometrium. in a premenopausal woman. Let's go to the thing that you know I'm going to talk about now and go to the secretory. And you ask yourself the same questions for the secretory as you did for the proliferative. Are there secretion vesicles in the either cells or in the lumen of the glands? And are there mitotic figures? So that's why we have a microscope. Let's zoom in. And well, first of all, the glands look a little more coily and elongated. And I think you'll agree that the endometrial stroma, or the specialized connective tissue between the glands, is a little plumper. But I challenge you to find a single mitosis. And actually, you probably can't. But can I show you something? What are these little vacuoles there? Some of them are at the base of the cells. Some of them look like they moved up towards the surface. Those are little secretion glands. And even though this is not the later part of the secretory phase, where there's a lot of secretion material in the glands themselves, you can at least say that we're starting to form little vesicles inside of the cells. Do you think they start out at the base of the cell or at the apex? They start out at the base, and then they move to the apex, and then you get the secretion material in the glands. And then as time progresses during the secretory or post-ovulatory or progesterone phase, you would then see this decidua right before the this endometrial stroma right before the menstrual phase, when the progesterone is highest, look like it's a little cuff of decidua. Only they don't call it really decidua. That's reserved for pregnancy. They call it pre-decidua. So here, I know there's some of you that are still thinking I'm imagining those vacuoles, so I'm going to show you some better ones. Oh yeah, I could see good ones, but I'm going to really find some great ones for you. Oh yeah, here you go. Here's some great vacuoles. We're going to really zoom in on this. So what's the bottom line? In proliferative, you look for mitotic figures. In secretory, you look for vacuoles or secretion. If you don't see much secretion, that there's probably going to be these vacuoles. Now you see that a lot of them are at the base of the cell, but some of them have already moved to the apex. And think about it. If a cell is going to secrete material into a lumen, and it starts out having vacuoles, it's probably going to start out having the vacuoles at the base of the cell, and because it's not going to be secreting anything into the lumen unless those vacuoles move to the apex, correct? It's just a mathematical thing. But here got some nice vacuoles, and we'll call that one a day as well. Okay, let's get rid of this. We did a little endometrium. Okay, I'm going to show you something interesting here. Okay, I'm going to show you this slide here for a couple reasons. First of all, it's skin. You could tell that. It's keratinized stratified squamous. Maybe you could see something like a hair follicle. You could see some eccrine sweat glands over here. You can see a hair follicle over here. And I'm going to show you normal skin, first of all. And the reason I want to show you normal skin is because it looks like any other normal skin in the body. You have a nice progression of a stratum germinativum, or basal layer, if you will, cells, getting generally more cuboid and flat until you get to the top. Then you have a stratum corneum. You know, big deal. But those are the main things you look at. Now, when we talked about carcinoma of the penis, squamous cell carcinoma, we called it Bowen's disease, okay? And in a Bowen's disease, you wouldn't have this orderly pattern of maturation. It might look like the cells at the base are almost similar to the cells at the surface, and there wouldn't be any maturation. But that's not why I'm showing this slide. I'm showing this slide because in that area, there's really not much inflammation in either the papillary dermis, which is the portion of the dermis between these epithelial pegs, or the deeper, denser reticular dermis. So the denser reticular dermis, which is loaded with elastic fibers, by the way, and the looser papillary dermis. They don't look terribly inflamed. But look, now we're moving towards some kind of lesion here. And you're seeing a lot of inflammatory cells. You don't see too many changes in the epithelium. You still have a nice maturation pattern all the way to the stratum corneum. But look, there's inflammatory cells here, there's inflammatory cells here. And so we have an inflammatory lesion of the skin of the penis. Well, you know what? As long as we have a microscope, let's use the high power. And I'm going to show you the nature of a lot of those inflammatory cells. Maybe we'll blow this area up over here. It doesn't want me to blow it up, but I'm going to blow it up anyway. And I have to ask you a very unfair question right now. Well, I'll ask you the easy question first. Are these basically neutrophils or mononucleated cells like lymphocytes? We're going to see what yeah, they're saying mono. So you know they're not neutrophils. It's not an acute inflammation. But here's the hard question. They're mononucleated cells, but do they really, really look like the tiny lymphocytes in which you just have a small lip of cytoplasm? Or can I convince you that probably a lot of these cells are plasma cells? Here, I'm going to find an area, and I don't want to look like I'm wrong, but I'm going to find an area where there's a lot of inflammatory cells. There's a classical plasma cell. There's a classical plasma cell. There's a classical plasma cell. So you not only have chronic inflammatory infections, but plasma cells. Now here's the thing I want to point out, because it's very important. Most of the inflammatory skin lesions of syphilis are plasmacytic infiltrates. Now this happens to be a primary syphilis. This is a chancre, okay? It's a painless inflammatory area. This is primary syphilis. But the wide variety of secondary skin inflammations in syphilis is also classically loaded with plasma cells. Here, and let me ask the final question. The final question is this. Let me find a really good cell. I can see a whole bunch of candidates, but I want to find a classical one. Okay. You see that cell right there at the tip of that little pointer finger? Is that a classical plasma cell? Do you see there's a big lip of cytoplasm coming out from the relatively round nucleus in a clear zone? Most of these cells are plasma cells. It's just that not all of them look classical. There's also one here that looks rather classical. So just the fact that you could recognize plasma cells is a good thing. Now, the reason why I showed you the normal skin as well in the non-inflamed area is because I'm going to show you another penile lesion. And look, here's penis. You can't really tell. You just think it's a bunch of connective tissue. Now, here are some epithelial cells. And can I ask you, does this look like normal skin, or does it look like it's not really maturing normally? This is a weird disease, and I hate to throw the term at you, but remember we said generically just about any squamous cell carcinoma of the skin, whether it's in the penis or anywhere else, is generally called Bowen's disease, almost synonymous with squamous cell carcinoma of the skin. Well, this is kind of a variant of Bowen's disease. It's kind of a pre-malignant lesion. You could call it sort of a carcinoma in situ. And this one has a weird name. You'll probably never hear it again. This is erythroplasia of Quay-Rat. You could Google it. You'll probably never have a patient that has it, but you will have plenty of patients that have pre-malignant and in situ skin lesions, anywhere in their body. Okay, that was just sort of a quickie. Let me just ask you the question. 2 questions about this before we go away. Number 1, can you tell this is a dysplastic pattern of skin growth? I'm asking the online people, and oh, well, most people are saying yes. Okay, and second question is a real easy question. What is this thick line over here, this thick dark line? Artifact, this little folding of the tissue. Okay, good. So we'll exit out this case too. Can I show you the world's most normal prostate now? What is it? Well, you have glands, you have stroma between the glands, and let's just do a quick little memory thing here is that, let's look at these glands. What is the feature of these glands? Well, they are all separated from each other by a nice little amount of connective tissue. And if you look a little bit more careful, you could see that in all of these cells you have a nice orientation of the nuclei at the base. Now there's a little secretion material. There's secretion material called corpora amylacea or concretions that are normal inside the prostate. This is not one of them. That's just some little sort of inspissated secretion. But let's back up for 1 second and do a couple clicks down to lower power. And whoops, that's higher power. And tell you, this is the world's most normal prostate. Now, what if somebody out there, who's really smart says, Dr. Minarcik, you're calling this a normal prostate, but in all honesty, wouldn't you have to agree that some of these glands have a lot of chronic inflammation around it? Don't you think a better name for this might be chronic prostatitis? Well, yeah, I would say when you see glands like this that are surrounded by mononuclear lymphocytes, you call it chronic prostatitis. So what's the best overall, most honest diagnosis to give to this slide? Normal prostate with a little focus of chronic prostatitis. Now, what's the most common cause for inflammation of the prostate, acute or chronic? Well, it's the so-called enteric gram-negative bacteria. Remember, E. coli, Pseudomonas, stuff like that. And of course, if it's an acute prostatitis and it's whopping and all these glands are surrounded by neutrophils, you have neutrophils in the lumen, it's likely you could culture out one of these things. But if it's chronic, your chances of culturing something are pretty slim. Okay, well, let's zoom back out on the microscope. Yeah, usually by the time an inflammatory process goes into the chronic phase, the bacterial presence is usually either not there or very, very hard to find. It's almost impossible to get a culture here from a prostate and a chronic prostatitis. And here we go. We're zooming back out more and more. And even though we're at the level now where we're just putting the slide against our white lab coat, and by no means do you see cells anymore. Can I ask you anyway, what are these 3 or 4 little red things out here, and there's another one here? You should probably know. I'm sure some of the people online are going to say, BV, blood vessels. That's what I would bet they are too. And you want to prove it? Sure you want to prove it. So let's zoom in here on Orlando, Florida. And guess what? They're not blood vessels. These are concretions, corpora amylacea. Remember those from your prostate histology? Let's see if the other one is a corpora amylacea too. It kind of looked like a blood vessel, but it's not. Let's go back and look at this one. Now, I bet you this is a blood vessel here, though. Yeah. That's another concentric, sort of calcified corpora amylacea that's normal in prostate, inspissated prostatic secretions. But let's see if that red linear thing at the bottom was a blood vessel or not. I bet it was. Oh, yeah, here's a blood vessel for sure, right? And so you could even see the red cells. By the way, you have to answer me honestly. I'm putting my hand over about, 200 little actual red cells. You can see the round outlines of them. So I know everybody online can see these, But can you see them as well? Okay, good, good. Then I'm happy. Let's move on to the next couple cases. Want to look at the world's most normal testicle? What are all these? They're all seminiferous tubules, aren't they? And can I tell you a funny story about seminiferous tubules? Have you ever gone to an autopsy where it's a man and he has cirrhosis? Well, when you go to an autopsy on a man that has cirrhosis, what is one of the first things the pathologist examines? It's the testicles. You want to know why? Because in cirrhosis, there's an abnormal balance between estrogens and androgens. And usually cirrhotic men have, you know, an abundance of estrogens and estrogen-like effects. And one of the estrogen-like effects is to counterbalance the androgens. So in a normal testicle, you can actually put forceps into the cut surface of a testicle and just take out those tiny little stringy tubes. But in somebody with cirrhosis, you can't. And it's a funny thing, and it's usually, you know, whenever a man has cirrhosis, they usually demonstrate that. Anyway, let's look at these seminiferous tubules. This is a good general area up here. Yeah, you could see that, you know, you got your share. You could see these nice tubules are delineated from each other with connective tissue. Let's go a little bit bigger. These are primary spermatocytes. When you see a primitive cell like that right at the base, like maybe there, you might call that a spermatogonium. And look at, now you have what look like normal sperm out here. You see kind of, you know, just a head. And anything that looks like a sperm, but has still a lot of cytoplasm around it, is going to be in this stage called spermatid. So what you have here are your maybe that's a spermatogonium. Most of these big cells are primary spermatocytes. Most of these cells here are sperm, mature sperm, but if you see something that has cytoplasm on it, it's spermatid. And by the way, it wouldn't be fair if I didn't find a Sertoli cell and an interstitial cell as well, right? So if you see a cell that's oriented more with rather than perfectly round like these primary spermatocytes, if you see a cell that is more oval shaped, but the ovalness faces from the basement membrane to the lumen like these, and has a nucleus like here, and probably here is a better example, that's a Sertoli cell. And of course, when you look between the tubules into the interstitial area, which we're going to do, every now and then you're going to find an interstitial cell. Oh, sometimes they're not easy to see. Ah, there's a couple of interstitial cells right there, clearly in their interstitium between these two tubules. Oh, and by the way, you see that cell there and probably here? These are Sertoli cells. And you want to find another interstitial cell just to be happy? Yeah, that's probably one over here. This is normal spermatogenesis. I'm going to show you one more testicle slide, and then I might be considered. I might consider ending it, or I might show you one more, because I know I got something here that's very, very important. Okay, here's another testicle. You can see this thick fibrous capsule. Remember, tunica albuginea. Does that sound kind of familiar again? And then you could see that there are things here that kind of look like tubules, but for the most part, it doesn't look like there's any cells in the tubules. And furthermore, and up here there might look like there's some cells, but for the most part, this entire testicle is void of viable looking cells that are creating the full spectrum of spermatogenesis. But what you see instead are these little big clusters of cells between the tubules in their interstitium. And remember, in the normal testicle, we had a hard time finding Leydig cells or interstitial cells. Look, here, they're all over the place. So I want you to remember now, when we're talking about the differential diagnosis of all the things that are associated with testicular atrophy, old age, estrogen therapy, radiation, anything that might affect the development of spermatogenesis. Now, there might be some tubules up here which have some remnant of perhaps a few spermatocytes. And there was even something there I kind of ignored way in the southeast that looks like there might be some tubules that have cells in them. But for the most part in atrophy, you don't have viable cells in the tubules. There you go. Now, is this complete spermatogenesis? I don't know. If you don't see sperm, you can't call it that. But I just don't know what I want to say about this. I wish they weren't here. I'm going to show you something here now. Wouldn't be fair if I didn't show you this. Well, what is this? It's pink. I don't know what this thing here is. Is it a wall of a big blood vessel? You have some stuff up here. Probably these might be inflammatory cells. You really can't tell. So that's why we have the high power on our microscope. Yeah, these are chronic inflammatory cells. Now, let's focus on this area here. You know that these bluer cells here are intrinsically different from these inflammatory cells and connective tissue cells that are around it. Okay? And let's blow it up even more. If I told you that this was an adenocarcinoma, or if I told you it was an adenocarcinoma of the prostate, you would probably say, well, how could it really be an adenocarcinoma? It doesn't really look like glands. Well, does that mean this would be a high Gleason's score or a low Gleason's score or grade? It means it would be high. In addition, do you remember I told you that the one main feature, if you want to remember, that differentiates malignant prostate glandular cells from benign prostate glandular cells is the presence of what structure in a nucleus? These cells all have nucleoli, don't they? If we were to go back and look at that normal prostate, or if you remember, hardly any of the cells had nucleoli. Plus, you don't have to really, know that. You could tell that these cells are big, they're pleomorphic, they're irregular, and this is a high grade, or Gleason's 5 adenocarcinoma of the prostate. And if the entire prostate looked like this, you would have to give it a Gleason's score. You have to take that 5 of the predominant area and add it to another 5 of the secondary area. Well, if it all looks the same, that's a 5 and a 5. That's a Gleason's score. I'm sorry, a Gleason's grade is twice the Gleason's score. So this is a 10, which is the worst kind you could have. What would be the best kind you could have? A 2, because that would be like a 1 and a 1. Okay. People get Gleason's score and Gleason's grade mixed up all the time. Even the urologists do, so don't feel bad. I think I feel pretty good that we've covered some of the main areas. I feel like maybe we can throw in one little thing here at the end. Oh yeah, well, let's do this. Oh no, I'll throw in one of these because I know it was on your exam, but let's see if I put it here. Oh yeah, you're going to love this one. Expect to see this very soon. Well, you say, why is Dr. Minarcik showing us normal skin? This is supposed to be a repro lab. Well, you know this is normal skin. There's a stratum corneum. There's a whole bunch of sebaceous glands over there. I bet you I could find a whole bunch of hair follicles, because if you have sebaceous glands, you have to have hair follicles, right? They don't empty into anything else. So this is very sebaceous. You have skin all the way to the point of having a stratum corneum. We'll move around. And I say, why is Dr. Minarcik showing us all this normal skin and sebaceous glands? I say, well, it's because it's not from the skin, it's from the ovary. And she's a young woman, And when you cut this open, it looked like cheesy and slimy, like there's a lot of sebaceous material. And this is a dermoid cyst, also known as a benign cystic teratoma. Or if you're kind of person that likes to put little letters and numbers, this would be the lowest number or lowest letter. So sometimes they call this cystic teratoma grade 0 or grade 1, but everybody calls them dermoid cysts. Okay, I think we'll call it a day. I think we had we didn't show everything in the lab that I wanted to show, but we've had a good time here. And I made this announcement at the beginning of the class when there were only a couple people here, and I'll say it again. We're going to have a nice review tomorrow. And what I'm going to do is make sure that the cases we review are really much zeroed in on the important parts of the what the USMLE considers important. Now, of course, the USMLE considers everything important. So if I was to say, study for the exam tomorrow, you'd probably just have to study everything, which is what you do anyway. But I'm going to have the privilege of zeroing in on the areas that I thought that they thought were important. Now, whether I think they're important or not doesn't matter. And I'm going to try very, very, very hard tomorrow, and even today, not to have my extreme contempt for the USMLE show. So I'm going to try to behave myself and pretend like it's a great exam, okay? We'll see you tomorrow at 8 o'clock, and have a nice day. Time for a closing song.
Can you hear the music well? Can you hear the music well?
Sorry to interrupt this beautiful music, but I have to have your response right now. Is it very, very high quality music, just like in Chicago? Yes or no? Rock on, you buzzards.